Okay, good morning. My name is Callie Boyer. I'm the Director of Marketing for here at Promises Behavioral Health. We're back with another month of PBHU. We've been doing this for well over 2 years now, and I'm really excited to have Darylyn Green from our The Right Step Houston location here this morning. So we'll be talking about motivational interviewing from confrontation to collaboration, motivational interviewing in action. I'm seeing that someone's hearing an echo. Does anyone else hear an echo from me right now? Do I sound okay, Darylyn?
Yes.
Okay. Okay, great. Let's go ahead and go to the next slide, please. If you do hear an echo, I can resolve that in the chat once I'm done introducing everything. Okay, so about Darylyn, I'm really excited to introduce her. She's our program director for the Right Step in Houston. She's actually brings over 15 years of experience as a licensed clinical dependency counselor, along with a master's degree in human resource management. She's deeply passionate about building a culture of trauma-informed care, something that really started taking shape early in her career while working in a therapeutic community center with the Texas Department of Criminal Justice. And then she joined the Right Step Houston in 2016 and has been making an impact there ever since. So 10 years at the Right Step, which is amazing. The Right Step itself has been open since 1990, so a lot of legacy there. And Daryl is also a proud member of the recovery community herself and recently celebrated 16 years. So she calls that her bonus life, which I love. And in her additional clinical work, she's a corporate trainer for Promises, where she handles our handle with care training and brings a strong focus on development into that group. So, on a more personal note, she's a Chicago native and a big sports fan. So, you'll find her cheering on both home team towns for her Houston Astros and the Bears, Bulls, Rocket, White Sox, and Astros. So, I'm really glad that she's here with us today. Please welcome Darylyn. If you want to go to the next slide. Okay, let me introduce Promises. So Promises, we have 7 treatment centers nationwide, both residential, outpatient. We have telehealth in Texas and Tennessee. So if you have any questions or interested in learning more about programming, I've been with Promises almost 7 years, and I would say that I've gotten the chance to visit all of these locations. And while they are all so different, the dedication we put on our clinical care is the same across every place. So, for example, Promises DFW, Promises Atlanta, both of those just opened last year. Meanwhile, the Right Step Houston has been around since 1990. The Promises Brazos Valley in College Station was one of the very first mental health residential programs in Texas. So, for all of you Texans out there, we do mental health residential for Promises Brazos Valley and Promises Dallas Fort Worth. Um, and let's see, the Ranch, Tennessee, we have a sexual recovery program, and the Ranch, Pennsylvania has an amazing dedicated outpatient center. It was voted one of the top recovery centers in 2025. And then Washburn House up in Massachusetts. If you were with us last month, you already got to meet the amazing executive director there, Andrea. And her clinical team has been able to extend the curriculum of care there to last for someone to be with us for almost 9 months, which is the longest curriculum in the state. So I'm really proud of everything that we offer. So if you have any questions, want to learn more, you can email me, Callie.Boyer at Promises, or that same email, PBHU at promises.com, will send you to me and I can set you up with a tour with resources. We're just happy to be here to help you all. So I can go to the next slide. During the webinar, okay, let's get into it. So you'll see at the bottom, there's a chat box and a Q&A. Know that those are separate pieces. So if you are in the chat box, you've already told me where you're from, which is wonderful. That is going to be for your questions regarding the technology. So the echo that you're hearing, anything else that I can help you sort out, you'll put those messages to me in the chat box. Darylyn may also ask you all to respond to a question or give you input. You'll also put that into the chat. I mostly just want to keep that Q&A for questions for Darylyn so that during the break when we come back, she can answer some content specific questions for you all and we can keep those places clean as possible. So thank you for doing that. You can go to the next slide. For the CEs, I know you're all here for CEs. So if you are here already, you're doing a great job. We just ask that you try not to miss more than 10 minutes of the training. If you have to hop out a few minutes early, that is a-okay. But just know also if you need to get into your car, you need to transition to your phone or some other device, that is totally fine. The Zoom will follow you. Just do it safely. And then just know that it's one device per registration. So if you're sitting in a conference room sharing this computer with more than one person, just know that the person that logged in this morning is getting the credit. So just don't share a device with someone else that you're with unless you're only one of you is needing the CEs. After the training, you'll go to your CE dashboard. You'll get an email just like you did for those reminders to go to your dashboard, and in there you'll see the survey. So once you complete that survey, your certificate automatically is put back into your dashboard, and then hopefully all of those will be saved and kept together. So at the end of the year, when you need to find those certificates, they're all in one place for you there. Let's see. And then also, you're getting two CE credit hours for NADAC and BCC. I know some of you are asking me about specific state boards or state licensures. Just know that I'm not an expert on these things. I just know that we're accredited through those two boards. So if you have specific state questions, I do ask that you check with your licensure. I can just kind of tell you what we see as a common attendee. So you might just want to double check that. And I think that's it on the CEs. You can go to the next screen. Next month. Okay, so next month is our only ethics training. So if you need ethics CEs, please join us next month. It'll be the only one we have for the year. I will put this link to register in the chat when I'm done for in a minute here, but that's going to be with Billy Anderson, who's also my co-lead as we develop PBHU. So he's a really wonderful speaker. He's really passionate about what we offer here, and it should be a great training. So I will put that registration in the chat here in a moment. Again, it's our only ethics CE credited training, and that's Friday, May 22nd, fourth Friday of the month, like usual. Okay, and then in addition, I've been talking the last few months about our new family webinars. So if you're sitting here, you work with clients, if they have loved ones in addiction, in recovery, in treatment, whatever path that they're on, and they just need a little extra support, we're offering monthly trainings for families. So that means that they can kind of come in and learn about codependency or learn about stages of change. And they're kind of it's an anonymous sort of training with other families that we do engage in chat and they can share. And they're totally free. And then the next week we offer a family support group. So that is more conversational. There's no training provided. You're just able to come in and ask questions about treatment, about admissions, about insurance, like however we can support the families. They're welcome to join us. So that's the second and third Tuesday of the month that I can put some information about that in the chat as well. So we'd love to see you or see any of like the families that you're trying to help, or these resources are free. Okay, you can go to the next slide. Awesome. Okay, I'm passing this over to you, Darylyn. Y'all, I'm in the chat if you need me. Thank you for being here. Darylyn, this is all you.
Great. Thank you so much, Callie. And welcome to all of you that are here. I am really excited to be part of the PBHU series. And today we're going to be talking about from confrontation to collaboration, motivational interviewing in action. Before we get started, I just wanted to give you a little bit about me. My name obviously is Darylyn, and as Callie said, I am the program director here at the Right Step Houston. I'm also a woman in recovery. And one of the reasons that I share that is because, there's been quite an evolution, both for the community of treatment. First of all, how did we go from confrontation to collaboration, but also my development from being an addict and alcoholic active to being a woman in recovery, and also from my beginnings as a therapist. I started as an LCDC working in a therapeutic community in TDCJ. And to me, that's pretty significant because it kind of goes with the title of this, because as any of you that know about TCs, it's all about confrontation. And when I came to promises, when I came to the right step, actually, I had to kind of reframe the way that I was treating my clients, the way that I viewed treatment as a whole, the way that I viewed my role as a therapist. Um, and that little funny thing, when I first came, they used to say, Darylyn, you're really going to have to tone it down a little bit because there'd be a client that was concerned about going to prison. And in my mind, I'd be like, no, that's not such a bad idea. They've got great treatment in prison. I have since evolved, just so you know. I believe that the experience here, my trainings in trauma informed care, the trainings I've received in abuse, neglect, and exploitation, the monthly trainings that I do in Handle with Care, which is about the way that we treat our clients and keeping trauma at the forefront with the way that we deal with them and the way that we deal with one another, has had a profound impact on the way that I see clients, the way that I view the counseling profession, the way that I view um, just interacting with people in general, because everyone has a story. So, we're going to go ahead and get started. And like I said, I'm giving you a little bit of background to where I am today. And that's kind of the journey that we're going to be taking today as we look at the development of substance abuse counseling and how we actually got to motivational interviewing. And there we go. All right. So, early views on alcoholism. From the 17th through the early 20th century, alcohol use wasn't seen as a health issue, it was seen as a moral issue. People believed it was a choice, a character flaw, a weakness of will. If someone struggled with alcohol, the response wasn't care, it was punishment. Fines, humiliation, even being placed in stocks where people were mocked or physically abused. Imagine that. Not help, but humiliation. So take a second and just think about this. If that's the environment that someone is living in, are they more likely to seek help or to hide? I can say that, it was in my experience, growing up when I did, because I was kind of a child growing up and during the sex and drugs and rock and roll kind of thing of it, where you were kind of expected to be able to handle all of these things and to live like that and continue to be able to perform, as a normie, as they say. Um, I know that if even then, when it was difficult to admit that there was something wrong and for people to look at you as though there was a moral failing, I would have been more likely, to really hide what was going on with me. So this model didn't just misunderstand addiction, it targeted the person and not the behavior. And when you attack someone's identity, you increase shame. And here's the part that matters for us today. Even though we've moved forward as a field, many of our clients still carry this belief internally. I'm weak. I should be able to stop. Something is wrong with me. So when clients come into treatment, they're not just dealing with substance abuse. They're often dealing with years of internalized shame. So if shame and punishment didn't create change, what actually does? That's where we begin to see a shift from confrontation to collaboration. So let's break this down a little further because this belief system wasn't just an idea, it shaped how people were treated at every level. First, sin and weakness. Religious and social traditions framed drinking as a personal moral failure, a conscious decision to ignore values and standards. This wasn't about health, it was about character. Second, what they called habitual drunkenness. Before we had language like addiction, people believed excessive drinking meant a lack of discipline, a failure of self control. So the assumption was if you just tried harder, you could stop. Third, the temperance movement. This intensified the message by framing alcohol itself as evil, which meant using it wasn't just unhealthy, it was immoral. So now we've shifted from you have a problem to you are the problem. So instead of punishment, people were managed through the criminal justice system, drunk tanks, jail, and public consequences. Let me ask you this. If someone is being punished for a behavior, how likely are they to be honest about it? I want to pause here for a moment because this slide isn't just history. It still shows up in how people experience treatment today. First, stigma and shame. For generations, individuals struggling with substance use weren't seen as people needing help. They were seen as people failing morally. So, what happens when someone feels shame? They hide, they don't reach out, they don't tell the truth. So, where do you still see shame showing up in your clients today? Just a little bit of something to think about. Second, lack of treatment. Instead of care, people were punished, told to pray harder, try harder, be better. There was very little understanding of the brain, trauma, or behavior. This is where the gap began between need and support. Third, social exclusion. People lost jobs, relationships, and community. They were pushed out and not pulled in. And when you isolate someone who was already struggling, you often intensify the very behavior that you're trying to stop. So, this is important because even though our field has evolved, many of our clients still walk in expecting judgment. They're asking themselves, am I going to be understood or exposed? Now, this is where everything begins to change because over time, the field started to ask a different question. What if this isn't a moral failure? What if it's a health issue? So in 1784, we see one of the earliest shifts, alcoholism being recognized as a disease, not just a choice. That idea didn't take hold overnight, but it planted the seed. By the 1840s, the Washingtonian movement emerges, and this is powerful because for the first time, people with lived experience began helping each other through shared stories. Connection instead of condemnation. Then in 1935, Alcoholics Anonymous, a major turning point. Now we see structure, community, and a model built around support, accountability, and shared experience. And as we move into the mid 20th century, the disease model becomes more widely accepted. And by the 1970s, we see the professionalization of counseling. Counselors are no longer just confronting behavior, they're using clinical skills, theory, and evidence based practices. And this is the shift I want you to really hear. We moved from what's wrong with you to what happened to you and how can we help. But even with this process, some of those older approaches, confrontation, labeling, tough love, they didn't appear overnight. And I'm going to go a little bit more in depth about each of these phases. I want to introduce you to someone who was far ahead of his time, and his name is Dr. Benjamin Rush. He wasn't just a physician, he was a signer of the Declaration of Independence and often referred to as the father of American psychiatry. So when he spoke about alcohol, people paid attention. In 1784, he published a pamphlet called An Inquiry into the Effects of Ardent Spirits on the Human Mind and Body. And in that work, he made a radical claim for the time that habitual drunkenness was not just a moral failure, it was a disease. Think about how significant that is. At a time when people were being punished, shamed, and publicly humiliated, he was saying This is something happening in the body and mind. He also introduced what he called the moral thermometer, a way of showing how different types of alcohol affected behavior and health. This was an early attempt to connect substance abuse with measurable impact. Now, his methods wouldn't align with what we do today, but his thinking marked a major shift. So Rush didn't just change how people thought about addiction, he also influenced how they treated it. First, the disease concept. He described alcoholism as a progressive condition affecting both the body and the mind, which was a major shift from moral judgment. This is the beginning of seeing addiction as something happening to a person, not just something that they are choosing. Second, his treatment approach. He advocated for abstinence from hard liquor, but interestingly, sometimes allowed beer or wine. So even then, there was still some debate about what recovery looked like. Now, this is where it gets important to understand the context. His medical interventions included things like vomiting, blistering, and bleeding, standard practices at the time. So today, that sounds extreme to us. But at that time, this was medicine. He also used aversion-based approaches, pairing alcohol with sickness to create a negative association. And we see that as we move forward through our history and development. And finally, he emphasized public health education, helping people understand that alcohol wasn't actually beneficial, which challenged common beliefs of the time. So here's what I want you to take from this. Rush moved the field forward, but the focus was still largely on the substance, not the person. So earlier I talked about a few of the eras along the way, and we're going to start by talking about the Washingtonians. Now, this is one of my favorite moments in the history of addiction treatment because it starts to look very familiar to what we do today. And before I started preparing for this presentation, I had no idea about this. So I'm very excited to share this for those of you who, like me, don't know anything about like the Washingtonians and how they began to impact how we treat substance use and self-help groups today. So in 1840, 6 individuals in recovery came together in Baltimore and formed what became known as the Washingtonian Temperance Society. Not doctors, not clergy, but people with lived experience. And instead of lecturing or pushing laws, they did something very different. They shared their stories. So think about that. What happens when someone hears a story that they can relate to? They feel less alone, they feel understood, and they begin to see possibility. That's connection, and connection is powerful. This approach spread rapidly, growing to nearly 600,000 members in just a few years. That kind of growth tells us something. It was meeting a need that hadn't been met before. But here's where things shifted. As the movement grew, the focus started to split between supporting individuals and controlling behavior through laws. And when that focus moved away from connection, the movement declined. So here's the takeaway. People don't change because they're told to. They change when they feel understood, connected, and capable. And if that sounds familiar, it's because that's exactly what motivational interviewing is built on: collaboration, evocation, respect for lived experience. So long before MI had a name, we were already seeing the power of connection over control. Let's look at how that continued to evolve. Now we come to one of the most influential movements in the history of addiction recovery: Alcoholics Anonymous. In 1935, in Akron, Ohio, two men met, Bill Wilson and Dr. Bob Smith. One was a stockbroker, the other a physician, two totally opposite sides. And both were struggling with alcoholism. What made this meeting different wasn't just that they shared the same problem, it was that they shared their experience, honestly, openly, and without judgment. Bill had learned from Dr. William Silkworth that alcoholism was a condition affecting the mind, body, and emotions. And when he shared that understanding with Dr. Bob, something clicked. Dr. Bob got sober and never drank again. And that moment sparked something much bigger: the creation of a model where people in recovery help other people in recovery. So let me ask you this. What is powerful about hearing something from someone who's actually lived it? And if you'd like to, leave a response in the chat, I would love to hear, your responses to some of these questions. As a matter of fact, I think I'm going to slow down a little bit because I'd like to encourage you to think about some of these questions and to participate, so that others can see this as well. And I think this is where I might ask Callie to let me know if people are responding because, oh, wait, I see some stuff.
Yeah,
Hey,
there's the chat there where you said
that's great.
nice.
Okay.
Oh yeah.
Connecting, hope, provides hope, connection, relatability, gratitude. It gives them motivation for them to persevere. Oh, I like this one. Oh, it's going so fast. Slow down. An acronym for hope: hearing other people. Where'd it go? Hearing other people's experience. I think that's what it was. Yay, that's awesome. Knowing you're not alone, especially from someone who knows the reality of addiction and trying for recovery. Yeah, awesome. Okay, this is fun, y'all. Okay, so reinforcement. It builds trust. It reduces shame. It creates credibility in a way that information alone can't. So AA didn't just stay local, it spread worldwide. And today, nearly 40 million copies of the Big Book have been distributed. And here's why that matters for us as clinicians. This model reinforced something critical: change happens in relationships. Between 1930 and 1980, we see one of the most important transformations in the history of addiction treatment. This is where the field begins to look more like what we recognize today. We move from moral judgment and custodial care to a more medicalized understanding of addiction. Now, addiction is being framed as a disease, something that can be studied, treated, and understood. during this time with the emergence of Alcoholics Anonymous, it was bringing structure, community, and peer-based recovery into the field. At the same time, we see the rise of aversion therapies. These were attempts to reduce use by creating negative physical reactions to alcohol. So what you see happening here is a field that is trying to figure it out. We also get the formal classification of alcoholism as a disease, which further legitimizes treatment. And then the development of structured rehabilitation programs, what we now think of as detox, residential treatment, and clinical services. So here's the big picture. The field moved from punishing behavior to trying to treat the condition. But even with all of this progress, something was still missing. We had models, we had interventions, we had structure, but we didn't always have the most effective way to engage people in change. So let me ask you this. Have you ever had a client who knew the information, but still didn't change? Let's think about that for a moment. Yes, absolutely. Often. So many. Yeah, definitely. We see a lot of that, right? Um, and just to kind of draw on what we talk about in recovery or in 12-step fellowships, that, we cannot stay sober based on self-knowledge, right? We can know so much, but still not be able to put that into action, right? That gap between knowing and doing is where motivational interviewing comes in. So the field begins to shift again from focusing only on treatment models to focusing on how we talk to people about change. And that's where motivational interviewing begins to emerge. We're entering a phase where the field really begins to formalize. This is where addiction treatment becomes recognized as legitimate healthcare. First, a major milestone. 1956, the American Medical Association officially classifies alcoholism as a disease. This is huge. It shifts the conversation even further away from moral failure and firmly into the realm of medical treatment. Next, we see the development of the Minnesota model. So this approach integrates medical care, psychological support, and 12-step principles into a structured treatment model. This is the foundation of many residential programs that we still see today. We also see the rise of hospital-based treatment units. Detoxification and counseling become more standardized, more accessible, and more clinical. Professional identity, very important moment. Then in the 1970s, we see the professionalization of the field, certification boards, and ethical standards, the creation of NADAC. This is where addiction counseling becomes a recognized profession and not just a role. So here's what we've built by this point. We have a disease model, a structured treatment programs, and professional standards. But even with all of that, we still see something in practice: confrontation, control, telling clients what they need to do. So let me ask you this, and I'm looking forward to these responses. How many of you were trained at some point to be more confrontational with clients? I can definitely share with you that I was. When it's needed, yes, confrontation was seen as integral. Originally, I was trained to be more confrontational. Oh, again, you were trained in Minnesota and trained to be compassionate. That was the approach once you established rapport. I see someone else that was trained in TDCJ. Yes, yes, definitely. Um, okay, it was called challenge. Okay, not in an aggressive manner, but yes, indirectly addressing concerns, asking the difficult questions. Okay, accountability and confrontation. So I can tell you, being trained in TDCJ, I was definitely encouraged and trained to be confrontational. Not that compassion wasn't always encouraged, but we even, when we were in that therapeutic community model, um, clients were encouraged to confront one another. We had groups that encouraged that, and at one point they used to have these things where they called, giving haircuts, and they would literally like sit across from one another and shout at one another, and we just kind of moderated those things. And looking back on that now that I've been in the medical model, I can see where there may be some use for that in conjunction with CBT. Um, but I definitely see much more sustained growth, sustained sobriety, sustained recovery, and sustained behavioral changes in the outcomes of clients that go through the model that we have now versus going through a therapeutic community. Let's see. Guys, I lost my place. Okay. So we've got in the 70s, the field began to expand in a really significant way. And this is where addiction treatment becomes more accessible, research driven, and integrated into healthcare systems. Sorry, I didn't finish. First, the creation of the National Institute on Alcohol Abuse and Alcoholism, NIAAA, in 1970. This was a major investment in understanding addiction through research, data, and science. This led to a rapid expansion of treatment services and clinical knowledge. So the field is no longer just reacting, it's studying what actually works. We also began to see the emergence of behavioral interventions. And these approaches focus on changing patterns, thoughts, behaviors, and habits. Some studies showed that 60 to 70% success rates for less dependent individuals at 1 year follow up. So now we're not just treating the condition, we're trying to understand and influence behavioral change. And then we see another major shift: insurance coverage. By the late 1970s and early 1980s, alcohol treatment begins to be covered by private insurance. Yay. This is huge because it moves treatment from specialized or public systems and into mainstream healthcare. But here's the key question. We now have research, behavioral strategies, and access to care. But do we have the most effective way to talk to people about change? So I think I asked you this before, but we come back to this. Have you ever had a client with access to treatment, but still not ready to engage? Access to treatment, but still not ready to engage. 100% yes. All day, all the time. Oh, yes. Absolutely an inpatient and not ready. We see that quite a bit. Yes, definitely. So that's the gap. Access does not equal engagement. And understanding behavior does not automatically change behavior, especially when ambivalence is present. So the field continues to evolve. You guys seeing the pattern here? I like it. Okay. From understanding addiction to understanding motivation. And that's where motivational interviewing begins to emerge. Now we're getting very close to where we are today. This is where the field begins to connect behavior, thinking, and motivation. First, social learning theory. Now, this reframes addiction as something that is learned through environment, experience, and reinforcement. But here's the thing. If something is learned, it can be unlearned or changed. Next, we see the rise of cognitive behavioral therapy, or CBT. Now, this approach focuses on how thoughts influence behaviors and teaches skills to manage triggers and prevent relapse. Now we're giving clients tools, not just rules. But even with CBT, there's still a challenge. Clients have the tools, but they're not always ready to use them. Have you ever had a client who knew exactly what to do, but still didn't do it? Every day, absolutely. Say I set up treatment 3 times for someone. They didn't go in till the third time. Let's see. Good question here. What about people who just believe that alcoholism is part of their culture? Definitely. I see that all the time. As a matter of fact, I can tell you that when I was drinking and people were trying to point it out to me, my maiden name is Duff. I had 3 sisters and both of our fathers were alcoholics and our grandfather was an alcoholic. And our response was, we are Duff girls. That's just what we do. And that was despite all of the negative consequences that were happening at the time. And I'm going back to the 80s with that frame of mind for myself. And it still didn't take until 2009 for me to get sober because I really just thought that's what I do. Yeah. We know what is and is not good for us, and we still use it. Seat belts, texting while driving, food, alcohol, cigarettes, vaping, and on and on. You are at, oh, somebody's great grandma's name was Duff. I'm on Ancestry, so maybe you'll find me. Anyway, let me get back to my presentation. I'm loving this interaction. Okay, so that gap between ability and readiness is where something new was needed. And this is where motivational interviewing emerges in the 80s. Developed by William Miller and Stephen Rollnick, MI does something fundamentally different. It moves away from confrontation and focuses on resolving ambivalence and increasing motivation. Because the question is no longer, do they have the skills? The question becomes, are they ready to use them? And instead of trying to push clients into change, we begin to work with them to draw out their own reasons. So everything we've talked about, the shift from judgment, the development of treatment, the understanding of behavior, it all leads here. Now let's take a deeper look at motivational interviewing. I want to share something that challenged the entire field. And this comes from William R. Miller, the founder of motivational interviewing. For a long time, the dominant belief in addiction treatment was this: if we confront people hard enough, if we break through denial, they'll finally change. As we mentioned before, some of us may have been trained this way, and we saw that we're not alone in this. But here's what research showed. The more confrontational the counselor, the more defensive the client, and the worse the outcomes. So what Miller found was this: empathy, not confrontation, was the strongest predictor of positive change. Not technique, not strategy, not intensity. Empathy. So now I'd like for you to think about your own experience. When has someone actually influenced you to change? Was it because they pushed you or because they understood you? Yeah, don't we all? Yes. They slowed down. They listened and had empathy. They related. They used challenge and empathy. I love this. Love is always, oh my God, it scrolls so fast, but it has something to do. Love is always more powerful than anything else. Yes. I do see the emergence of dual diagnosis, and maybe we can talk about that during the Q&A, because I would love for everyone to engage in that question. When they understood my why, they showed up when others didn't and gave grace with love while also teaching and leading by examples. They shared their struggles and understood mine. They held space for me. Yes. So we can definitely understand how this impacts our clients. So this doesn't mean that we avoid difficult conversations. It just means that we approach them differently, right? Miller reframed confrontation in a powerful way, not as something we do to clients, but something we help them come face to face with themselves. So instead of saying, you need to change, we say, help me understand what's going on for you. Because when we push, people resist. But when we understand, people open. And that's the foundation of motivational interviewing. So we talked about how long we believed that if we confronted people hard enough that we could break through denial. And that approach didn't come from bad intentions. It came from a belief that people couldn't see the reality of their situation. So we had to show it to them. This led to what was often called denial busting, challenging, pushing, sometimes even breaking people down to build them back up. We saw this in the early therapeutic communities and in some parts of the Minnesota model. But over time, research began to tell another story, that there was no consistent personality profile for addiction. And it reinforced what we've been talking about. The more confrontational the counselor, the worse the outcomes. So, in contrast, counselors who demonstrated high levels of empathy had significantly better outcomes. So, empathy isn't just a nice approach, it's actually an evidence-based predictor of change. So we talked about the meaning of the word and what true confrontation is. It actually means to come face to face. Confrontation is not about pressure. It's about helping clients come face to face with their own reality. That forceful, aggressive approach actually increases defensiveness, the very thing that we're trying to reduce. And for many clients, especially across different cultures, direct confrontation can feel disrespectful, shaming, or unsafe. People don't open up when they feel pushed. They open up when they feel safe enough to be honest. And we can continue to see how our role shifts from forcing insight to facilitating discovery, from breaking denial to exploring ambivalence. So if empathy is the foundation, what does that actually look like in practice? And that's where we move into the core skills of motivational interviewing. But what we cannot do is talk about motivational interviewing without reviewing the stages of change. So this model you're looking at, the stages of change, that tells us where a person is in their readiness to change. Motivational interviewing tells us how to respond based on that stage. Stages of change is the map. MI is how we navigate it. Pre-contemplation. They don't see a problem yet. The motivational focus, build rapport, raise awareness, and avoid arguing. For example, you're not convinced this is an issue right now. Contemplation. They're ambivalent. I see the problem, but I'm not ready. Motivational interviewing focus. Explore ambivalence. Evoke change talk. For example, Part of you wants things to be different, and part of you isn't sure. Preparation. They're getting ready to change. Motivational interviewing focus, strength and commitment, help with planning. Example, what steps feel realistic for you right now? Action. They're actively making changes. MI focus, support effort, reinforce progress. Example, you've been putting in real work to change this. Maintenance, they are sustaining change. The MI focus is on preventing relapse and helping to build confidence. For example, what's helping you stay on track? Relapse. Relapse is not failure. It can be, for some people, just part of their process. The motivational interviewing focus, reduce shame, and re-engage. Example, what did you learn from this that can help moving forward? The biggest mistake we make as clinicians is using the wrong approach for the stage. If someone is in pre-contemplation and we jump straight to action planning, they resist. But if we meet them where they are, they engage. MI is about meeting people where they are, not where we want them to be. Think about a client you've had recently. What stage were they in, and did your approach match that stage? You guys still thinking, or should I move on? If anyone would like to share. Window button, oh, for screen capture? Thank you for telling me that. I saw something. How do we match that when they're in pre-contemplation, but being required by CPS? I don't know, does anyone have any suggestions about that? One is that you have one that's in pre-contemplation, move too quickly since his job was on the line. Yes, mandated clients, sometimes they are not ready for change. But we can definitely plant that seed. We can definitely plant the seed. Roll with the resistance, yes. It's hard when a client says they're ready, but their behaviors show otherwise. Oh yeah. Okay, with CPS, sit with them and acknowledge where they are and what they can do in the here and now and moving forward. That's a really good response to that. There's if I could give example of how to frame questions, we're going to talk about that more in depth in a little bit further along. I asked, what do you think would happen if you do not change? Okay. Great responses, y'all. So that's where we go, instead of asking, why aren't they changing, into what did I just do? Let me go back, sorry. So we go back to why aren't they changing? And the shift moves to what stage are they in and how do I respond effectively? Um, so I guess, Callie, it's 10 o'clock. If we should take a 5 minute break now, I still have quite a bit to do.
Up to you. If you think we need to keep rolling, we can skip the break. If anyone needs to use the restroom or refill their coffee, you're welcome to just do that and come back. Unless you yourself want to just take 5 minutes, Sterling. Up to you.
No, I'm ready to roll. I hope you guys are ready to roll because I'm ready to
Yeah,
roll.
let's keep rolling.
Okay. So, up to this point, we've talked about models, history, and research. But this right here is how motivational interviewing actually feels to a client: empathy and understanding. Empathy is the foundation of motivational interviewing, not sympathy and not agreement, but understanding. Empathy means we are actively trying to see the world through the client's eyes, without judgment, without correcting, and without fixing. Think about a time when you felt truly understood. What did that do for your willingness to open up? I feel sorry for you versus I feel sorry with you. It motivated you, felt safe. I wanted to open up more. Yes, empathy facilitates building trust and opening up. Hey, CPS worker there. Gave a safe place to explore my feelings more and my motivation. Empathy equals understanding, equals safety, planted seeds of trust, a safety net. Could feel the strength of shared approach to an issue. Definitely. Heard and accepted. Created a brave space for self disclosure. I love that. I love that. It made me want to connect authentically with that person. So, when people feel understood, they become more open to change. Like we said earlier, MI is not something we do to clients, it's something we do with them, a collaboration. Instead of directing the conversation, we explore together. We move from expert to partner. So, for example, it goes from you need to stop using to help me understand what role this plays in your life. And I'm sorry, I want to pause here. I can really like that really resonates with me because there was a time during my active addiction where I felt so overwhelmed that I was doing everything for my kids, for my job, for my husband, for my family. Um, that when I became overwhelmed, my use was the one thing that I felt was mine. That was my reward. And it actually took being in treatment with an amazing therapist for me to come to understand why it was so important to me and why it was so difficult for me to let it go. Wanted to share that. So, people are far more likely to believe what they say than what we tell them. Fostering autonomy and trust. One of the most important principles in motivational interviewing is this. Actually, in therapy, the client has the right to choose. Even if we don't agree, even if we're concerned, we respect autonomy. And here's the paradox. The more we try to control, the more resistance we get. But when we support autonomy, we reduce resistance and increase engagement. People are more likely to change when they feel the change is their idea and not ours. So when you combine these three, empathy, collaboration, autonomy, you create something powerful. A space where people feel safe enough to be honest and strong enough to consider change. So, which of these comes most naturally to you? Empathy, collaboration, or respecting autonomy? Respecting autonomy, yeah, ultimately it is there. The three braided together work fabulously. Yes, autonomy and trust. Respecting autonomy. Truly, it depends on the person you're talking to. Yes, definitely. You know, I'd like to say that with every client that I work with, that I'm doing all three, but sometimes that, wanting it so badly for them, you know, and wanting to tell them, but if you do this, this is going to happen. But how do I express that while still respecting their right to choose? And it's hard. It's hard sometimes, especially when you see someone who is in end stages of alcoholism, and knowing that you don't know which drink might be the last. That is a hard one. Remembering that this is their treatment. I cannot want them to get better more than they do. Yes, sometimes it's hard not to want to give advice. Okay. So the next question becomes, how do we actually do this in conversation? And that's where the core motivational interviewing skills, ORs, that's where they come in. Now we're moving into the core skills, y'all. And instead of just talking about them, we're going to practice them live, even in a virtual setting. All right. So, quick check-in. Drop this in the chat. What is one word that describes how confident you feel using motivational interviewing right now? I love that. Rusty. Yeah. Poor, comfortable, not super confident. 70% could always use improvement. Wanting to, but need to be slow and thoughtful. Okay. Somewhat beginner. And sometimes every time I meet a client, I feel like I'm a beginner. Ah, Haley, I've learned this so many times and haven't been able to fully grasp. I just want y'all to know that when I picked this topic, I was like, why did I pick this topic? But anyway, I am learning with y'all. Okay, so I'm really seeing a mixed, confident, unsure learning, and that's exactly where we want to be. So I'm going to demonstrate two approaches using a common client scenario. A client says, I know my drinking is causing problems, but I'm not sure I want to stop. Okay. The non motivational interview approach would be, you really need to stop is clearly a problem. And have you tried avoiding situations where you drink? In the chat, tell me, what did you notice? Blame. Yeah. So once again, if we responded with, you really need to stop is clearly a problem, and have you tried avoiding situations where you drink? Some of the things that I'm hearing: pushy, judgmental, closed-minded, reinforcing resistance. The client is not in control. The therapist is being pushy and ignoring the client. Why do they need to stop drinking? Okay. Definitely. Direct, authoritative, paternalistic approach leading to shame. Not respecting autonomy by telling them what to do. It's giving advice that wasn't asked for. Okay. So we've got the motivational interviewing approach using ORs. Well, what do you enjoy about drinking? What concerns you about it? Notice that these aren't yes or no questions. We're opening space. Reflective listening. It helps you relax. And at the same time, you're starting to see some consequences. So I'm not fixing, I'm just reflecting. Affirmations. It takes a lot of honesty to say that. You're really paying attention to what's going on. We affirm the effort, not the outcomes. Summarizing. So drinking helps you unwind, but it's also starting to create problems. And you're not sure what you want to do yet. Did I get that right? So type in the chat, what felt different about that second approach? Validating, curiosity, stayed with the client, non-confrontational, meeting the client where they are, more empathetic. Collaborative, room for the client to decide. Nurturing, allowing space for the client to agree or disagree. It's a conversation, not judgmental. Genuineness, support, validation. Yes. Validating. So, ORS is not about controlling the conversation. It's about guiding it in a way that reduces resistance. When we ask, they explore. When we reflect, they hear themselves. When we affirm, they believe that they can change. So a client says, I know I should exercise more, but I'm just tired all the time. Could you guys type one reflective response in the chat? I know I should exercise more, but I'm just tired all the time. A reflective response. Being tired must be a challenge for you. You want to be more active, but you're too tired. So you would like to exercise, but your energy level makes that difficult. It sounds like getting exercise is really getting in the way. I'm sorry, what's so fast? What I'm hearing you say is you want to exercise, but you're struggling with your energy. It sounds like you want to exercise, but being tired keeps you from meeting your goals. Okay. Great responses. So, which one was harder? Asking or reflecting? Asking, reflecting. Yeah, I'm on the reflecting team. I have a knee jerk reaction to want to ask the question. Yes, yes, exactly. Reflecting because you have to find the right, respectful way of doing it. I love that. Reflecting takes more reflection. Yes, Lisa. Definitely. Okay. So think about like when someone reflects you accurately, you know? I'm like, wow, they really heard what I said. Yeah. Oh, yeah. It makes me think about really what it is that I'm saying as well when I hear that. And that they understood and that they hear me. So these skills may seem simple, but when used intentionally, they create real movement in conversation. Next, we'll look at how these skills will help us work with ambivalence. We're going to focus on one of the most important skills in motivational interviewing, learning to hear what the client is telling us about change. So, this is the core concept. Clients are always telling us two things at the same time: why they might change and why they might not. Change talk, statements that move toward change. Examples from the client's perspective. I know this is affecting my family. I want to feel better. I need to do something different. Sustained talk. Those are statements that keep things the same. It helps me relax. I don't think it's that bad. I've tried before and it just doesn't work. I hear that all the time. Both are normal and neither is bad. So I'm going to read a few statements. Type in the chat CT for change talk or ST for sustain talk. All right, first statement. I know this is starting to affect my job. Yes, change talk all the way. All right, next statement. It's the only thing that helps me cope. It's the only thing that helps me cope. ST. Great. Next quote. I guess I could try cutting back. I guess I could try cutting back. Change talk. Next quote. I don't think I'm ready to stop, y'all. I don't think I'm ready to stop. Sustained talk. We'll do one more. My family is really worried about me. Change talk. Yeah. Okay. So we're going to level up. Let's make it a little bit more realistic because clients rarely speak in one direction. Okay. I know drinking is causing problems, but it's also the only way I relax. What do you hear? Change talk? Sustain talk? Both. Both. Lots of both. Ambivalence. Winner, winner, chicken dinner. Exactly. This is ambivalence. Here's where motivational interviewing becomes powerful. What we choose to respond is what we strengthen. What we choose to respond to is what we strengthen. So if we argue with sustained talk, we get more sustained talk. If we reflect change talk, we get more change talk. So what you reflect, you reinforce. Okay, so here's a response practice. Let's practice responding, okay? Here's the client statement. I know this is affecting my health, but I'm not ready to stop. Type one reflective response that leans towards change talk. It sounds like you know this is impacting your health. You want to be healthy, but it's difficult. How important is your health to you? It sounds like you are feeling like using this substance is impacting your health negatively. Sounds like you're concerned about your health. Sounds like you're aware that this is affecting your health, but you're not sure about how to change. Oh, describe a time your health wasn't an issue. I think that's what it was. Okay. All right. Notice that we're not arguing with the not ready part. We're strengthening the change side. So instead of asking, how do I get them to change? We shift to what change language is already there? What can we work with? Because they're giving us something to work with. And how do I build on it? And the skills that we just used, reflecting, affirming, those are the same ORS skills, but now we have a direction. You don't create motivation, you evoke what's already there. At the heart of motivational interviewing is a deep belief in the giant. At the heart of motivational interviewing is a deep belief in the client's ability to change, not because we tell them to, but because we help them recognize it in themselves. Encouraging autonomy. MI is grounded in that one core principle: the client has the right to choose. Even when we disagree, even when we're concerned, we respect autonomy. And here's what we know. We've talked about this before. The more we try to control behavior, the more resistance we create. Autonomy doesn't weaken change, it strengthens it. Many of our clients come into treatment carrying shame, failure, and self-doubt. And our job is to help them see something different: their strengths. You showed up today. That matters. You've made changes before. You're capable. When people start to see their strengths, they start to believe that change is possible. Motivation isn't something that we give to clients, it's something that we draw out of them. We help them connect. We help them connect behavior with consequences. We help them to connect values with goals. And thirdly, we help them to connect their present to their future. People commit to change when it aligns with what is most important to them. Change is not a single moment, it is a process. And motivational interviewing helps clients stay engaged in that process through setbacks, through ambivalence, through uncertainty. We remember that relapse is not failure. Relapse is feedback. Our role isn't to help clients from falling, it's to help them get back up differently. So when we combine all of this, autonomy, strengths, motivation, support, we create something powerful. A client who believes, I can do this. Make sure we have enough time. The question becomes, how do we consistently bring out that belief in conversation? That's where motivational interviewing skills and strategies come together. People don't change because we convince them. They change because they begin to believe in themselves. This is a small shift, and I want to cover this. We'll go through this pretty quickly. this makes a difference. And we're going to talk about the difference between affirmations and praise. Both are positive, both are well intended, but they land very differently with clients. Affirmations are a core motivational interviewing skill. They focus on who the client is, not just what they did. They highlight effort, they highlight strength, and they highlight values. Here's an example. You've been really persistent in trying to repair that relationship. It's specific, it is strength based, and it is client owned. Affirmations build self efficacy, the belief that I can do this. Praise, on the other hand, tends to come from a very different place. It often sounds like, good job, I'm proud of you, you're doing great. It can unintentionally put us in the position of being the evaluator. Okay? When clients feel evaluated, they may seek approval, become dependent, or feel judged if they are struggling. Affirmations say, you have what it takes. Praise says, I approve of what you did. Instead of saying, good job staying sober this week, we can shift to, you really showed commitment this week. That says a lot about what matters to you. Same moment, very different impact. The best affirmations link behavior to identity. For example, you kept showing up even when it was hard, tripping over my words. That tells me that you're someone who doesn't give up easily. Affirmations don't give confidence. They help clients recognize the confidence that they already have. So as we continue building motivational interviewing skills, it's not just what we say, it's how it lands with the client. If a client only feels good when we approve, they won't know what to do when we're not there. Another one of the most important principles in motivational interviewing is this: we don't install motivation, we evoke it. And as we've said before, it's drawing out what is already inside the client. So instead of telling clients why they should change, we help them to discover their own reasons. Change is far more powerful when it's personal. For example, we don't say you need to stop drinking. We say what concerns you most about your drinking right now. People believe what they hear themselves say. Evocation helps clients connect their behavior to what actually matters to them. Examples of this are family, health, integrity, stability. And examples of this can be, what kind of parent do you want to be? What matters most to you right now? When behavior and values don't match, motivation begins to grow. Motivation that comes from within is far more sustainable than motivation that comes from outside. So we're not pushing change, we're helping clients feel the reasons for change. Once clients begin to hear their own reasons, they naturally move toward commitment. So, for example, some questions could be, well, what do you think your next step might be? Or, well, where does this leave you now? Commitment language signals readiness. The writing reflex says, let me fix this for you. Evocation says, Help me understand what matters to you. People don't change because we give them reasons. They change because they discover their own. So when we combine navigation with our core skills, we move from directing change to guiding it. I think this would be a good time for a 5 minute break for just a few questions. And then I'm going to close out if that's okay with y'all.
Yeah, Daryl, and there are some questions in the chat there. So if you want to, I'm not sorry, not the chat, in the Q&A.
Mm-hmm.
If you want to address those, we can have about 15 minutes of Q&A now. And if anyone has any additional questions for Daryl, you can put those in the Q&A down there.
Thank you.
Do you see where those questions are?
Yeah, I
Great.
do. Okay.
And I'll share too while she's looking those over. Just a reminder, May 22nd is our next webinar. I'll put a registration link to that in the follow-up email. You'll get an email saying if you were here for the full time to qualify for the CEs. So you'll see that email and then a link to the eval there in your email. And then I'll also send you the YouTube follow-up, any slides that were shared today, and again, registration for next month. So thank you all for being here. If you want to stay on, we do need you to stay for the full time of the webinar to receive those CEs. So we're going to do just 10 to 15 minutes here of questions. So whenever you're ready, Darylyn.
Mm, I think I'm better at explaining than answering. Let's see, I can say I'm sorry, but I don't have any handouts that to print out. But what I'm
Yeah.
thinking is that maybe we could attach some later.
Yeah, oh for sure. We can send anything in the follow-up email. I could put them in their dashboard. I know you referenced a video that you really found helpful. We can include links like that too. So
Okay,
we'll
great,
follow up with some resources. Yeah.
great. The emergence of dual diagnosis. You know, when it comes to the emergence of dual diagnosis, I'm an LCDC. So the things that I focus on are mainly with that, but I always try to make sure that there's a therapist or a psychiatrist. Like here at the Right Step, and I believe with most treatment centers, we've got that entire team. You know, we've got our nurse practitioners that come in regularly, and depending on the severity of their mental health acuity, there are things that they deal with on that end with the medication management, with the other things that they need to explore. And we try to just focus on the, the parts that we can, and sometimes breaking them down into even the smaller goals, because where we are, our clients, we have a lot of people, Medicaid, homelessness, lots of issues that they have going on. And we find it easier when just to figure out what their primary goal is and to do the motivation for that on our end, because it can be so overwhelming. What would be something you could say to plant a seed in someone who was in the pre-contemplation stage? Well, what have I said? Um, you know, I think for me, in a way that I approach this, I because of recovery side, and there are times that it's pretty difficult to separate the two, is to kind of focus on, asking them if, if they've considered, why they are, why they're here. And is there something that they can get, because usually by the time we've had an individual, they've been to some groups, we've had our assessment and things like that. Ask them if if there's anything that they feel that being here could help them with. Even if they don't think it's something that could help them, if they don't feel that they have a problem, sometimes it's well, maybe we can focus on, my relationships, on how I can get something out of here to, to share, why I do what I do with my family. Focusing more so on that aspect of it. Trying to identify one benefit in their life. That way they have a goal to look forward to. Yeah. Is it useful to explore the obstacles presented in sustained talk, or better to strengthen change talk? I would say focusing more so on the change talk, because those are the things that we're really. I'm a firm believer in what you feed yourself. I try to think about what it is that I feed myself, what I'm listening to. What type of music am I listening to? Am I listening to gang rap, or am I listening to Christian rock? Um, if I'm the TV shows that I watch, when I was using, I watched Snapped on repeat every weekend. Now I watch Love It or List It, motivational thing, like things that I aspire to. Yeah, I want to come up with $250,000 to keep to love my home. But yeah, I really do believe in you focusing more on, what it is that you're feeding yourself. And so what is it that we're feeding our clients? Let's see. Oh, my mouse is not the best. A good book to learn more about good responses in MI. We'll definitely provide some links for that. A good response, what would you say when a client responds with "I don't know"? I tell them that it's okay, that they don't have to know the answer right now, that they can think about it. At what point do we get a little more confrontational? For example, they've been in this contemplation stage for like years, and now they are in liver failure. I think that, when we look at the stages of change, and that's where we are, that we kind of stick with what works in that stage and continue to try to evoke what it is that is important to them. And also what I find in things like that is that there's a lot of depression that goes along with that, and working with other professionals during that stage, because I don't know that if they've been doing this for years, that there's anything that they haven't heard from a therapist, you know. More examples of affirmations. Guys, I'm going to be honest. I'm looking at the time, and believe it or not, and I was told that this was going to happen. I am on slide 29 and I have 43. So I don't think we're going to come to my big finish, unless I click real fast and be like, okay, this is a good one. But the good thing,
Maybe
though,
we can do a part two at some
you
point.
know, I'm down for it. I totally am. If you guys want to come back, I can't do it next month because they already got people lined up. I would love to, though. like I would love to do a part two. And maybe, I know that this one is being recorded, so maybe you guys can maybe review this before we do the next one. Anyone that wants to come back, if we can slide something in the next couple of weeks, like, y'all, I'm down. Um,
Yeah, well, we can
that's
we can
that's a Cali thing.
yeah, we can work that out. I like that idea a lot. And I do think there's a lot here. And I figured that we would go long because there is so much to this, I think. And if we really want to get into the depths a bit, then we don't want to rush
Yeah.
through that. So,
Like I've got some case presentations. I've got some stuff like for families and how we can like empower families and how you can talk to family members and take off the clinician hat, and like then just be you with your loved one.
mhm.
There's so much left that we can unpack with this.
Yeah.
Um,
And I think if you want to speak to one other piece, I think there were a few questions that came up around this and just speaking to how do you incorporate or do you ever incorporate your own story, your own sobriety when you use MI with your clients?
ooh, you know how stuff has kind of come up like even during the presentation. I do. I do quite frequently. I do believe that our lived experience is so much a part of who we are, our why for what we do, and the ability to connect. That is our greatest strength. That experience, that connection, that empathy. Even when I don't have the answers, there have been situations where I actually had a client yesterday who kept saying, like, you all don't know where I've come from. You don't know what I'm going through. And someone was saying, well, yeah, I kind of do. And then when she said, well, my brother was shot 22 times. Have you ever held someone as they died in your arms? And, the best thing that we could say was, I haven't experienced that, but I've experienced pain and loss. And I'm so grateful that you're willing to share that with me. And that truly, to me, is one of our greatest strengths. We talked earlier when we were doing like the historical part of it, and I know I didn't go into a whole lot about it, but early on, um, counselors we were paraprofessionals, and it was very difficult to separate our 12-step approach or our recovery from the way that we actually counsel people. And we may not use a 12-step model. Here at Promises, we actually, we used to be a lot more 12-step based at the right step. We do incorporate it, but our focus now is more so on evidence-based practices. But we still provide meetings. We still encourage them. We still, make sure that is part of their aftercare planning. So it's very difficult to divorce that and still come up with a full, well-rounded plan that involves, mind, body, spirit, that feeds all of those things. The importance of connection and with our alumni association, and the meetings that they do and the outings that they do. I mean, there is so much of what we do that is rooted in that connection. And that really is one of our primary focuses and purposes.
Yeah, I think it builds trust, right? And even at Promises, we always like to encourage folks that are in recovery themselves, like those are the people we want working with our clients every day to give them that insight. So I think it really makes a difference. So um
One
go
more
ahead.
thing that I wanted to bring up along those lines, because something that I get a lot is people that feel that if you're not in recovery from alcoholism or addiction, then how can you help me? How can you understand? And I think that that's something to think about and to talk about. Recovery is recovery. Addiction is addiction. I had to take a Monopoly Go off my phone. Okay, I haven't looked at Candy Crush in 4 years because they were getting half my paycheck, and that's just real talk. So whatever it is, be it gambling, be it porn, be it food, be it relationships, be it shopping, the addiction doesn't have to be the same for the motivation and the consequences, the shame and the guilt and the inability to stop doing something that continues to harm you in some way. Those things, those are interchangeable. So I encourage you, you don't have to talk about like I did and, have my paycheck going to Candy Crush. But I'm sure that there's a way that we can incorporate those so that we can build that trust and foster that empathy with our clients.
Absolutely.
Yeah.
Well, y'all, I think we're gonna pause here. I will schedule us a part two. If you are already following us on LinkedIn, I always share the updates there. You're gonna get the follow-up emails. Um, Please fill out your evals. Know that we read all of them. I'm always taking your input as we start talking about these new trainings, even for 2027. So just know that we read them all and really appreciate you all being here. Enjoy the rest of your weekend. Darylyn, thank you. This was wonderful. I'm so
Thank
sorry you have
you.
to come back and do
Oh
more
my
with
God,
us
thank
because you
y'all.
did
Like
a
the,
good
the
job.
responses, the feedback, like your participation, like, man, that feeds me. So thank you so much.
Yeah, thank you all. Have a wonderful rest of your weekend. We'll see you real soon.
Bye.
Bye.